And the title of my talk is Protein and Fibril-Directed Therapies in AL Amyloidosis. I'm actually going to expand that topic just a little bit and discuss fibril-directed therapies in both AL and ATTR amyloidosis. These are my disclosures, and the relevant ones for this particular talk are advisory work with Prothena and Calum. As we've heard from other speakers, organ injury is mediated by misfolded light chains and aggregates of misfolded light chains. There's a cytotoxic effect of these soluble species, and there are different sized species detectable, not ones that we measure with the serum free light chain assay, but certainly in the blood. And it seems likely that the aggregates are actually more toxic perhaps than just the misfolded light chains themselves. Here we have an example of cardiomyocytes exposed to control light chains and NT-proBNP expression. We see that misfolded light chains that are not in aggregates do increase NT-proBNP production, and light chain aggregates do so even to a larger degree. We've seen previous work published that cardiac damage is mediated by P38 alpha MAP kinase and hemoxygenase 1, and this work shown here shows that inhibitors to those intracellular signaling pathways, particularly hemoxygenase 1, can at least partially abrogate the effect of the free light chain aggregates on cardiac cells. We have interest, therefore, in targeting these toxic aggregates and also in targeting tissue deposits of the amyloid fibrils as well. The first agent I'm going to talk about is NEOD-001, which is an IgG antibody that targets a specific epitope that's in the variable region of the light chain, of the misfolded light chain, and various amyloidogenic light chains have been tested, and the epitope at the 8182 amino acid position in the light chain is fairly preserved across patients, and at least 90% of the samples tested were bound by NEOD-001. And when I mention 2A4 is simply the murine analog of NEOD-001. And what we see here is biopsy material from the heart and kidney of a patient with AL amyloidosis, and we see that there's no binding of amyloid deposits by a control isotype antibody, but the murine 2A4 antibody does localize to amyloid deposits in both of these tissues. This work led to a phase 1-2 study that's been published, and this is work that's been published in an effort led by Maury Gertz at the Mayo Clinic. This was a phase 1-2 study with a 27 patient run-in dose escalation with doses ranging from 0.5 to 24 milligrams per kilogram, with dose escalation permitted within these patients as we climbed up this ladder. Following this, additional patients with cardiac, renal, and peripheral neuropathy due to their amyloidosis were included. Now, these patients were all patients who had been previously treated with chemotherapy, had completed that therapy, had had a response, and would otherwise be observed. Okay, so these are patients. So the idea here was first, obviously, to evaluate the safety and tolerability of the drug, to determine the MTD or the dose used for future trials, but importantly, some of the other type of work like pharmacokinetics, immunogenicity, and then some exploratory work looking at whether there is any evidence of organ responses, since what we're targeting is the protein and not the plasma cell clone. So with regards to the heart, in the phase 1 and phase 2 expansion group in total, there were 27 patients who had cardiac involvement of amyloidosis, and of these 27, a little bit more than half actually had an NT-proBNP reduction during the course of the study that met criteria for a cardiac response. Among 23 patients with kidney involvement, renal involvement, proteinuria was decreased in the majority of patients, and in about a third of them, it was decreased to the point that it would be considered a renal response, including a handful of patients who actually had complete resolution of proteinuria while on the study. Dr. Litke led some subgroup analysis work analyzing the patient population to see whether there were any clinical predictors of responses, and it turns out that the type of prior therapy, the degree of prior hematologic response, and the time from prior therapy did not correlate with organ response, suggesting that this was actually an effect of the antibody and not necessarily or not as likely to be a result of the prior therapy. So this work led to several studies, including some randomized studies, and I'm only going to talk about the first two because these are the most relevant in terms of the sort of the current status of the NAOD-001 program. The first is the Pronto study, which is a randomized phase 2B trial in a very similar patient population to the group that we just saw. These are previously treated AL patients who had cardiac involvement, residual cardiac involvement, and who had had at least a partial response to last therapy and were not going to be getting additional therapy at the present time. Patients were randomized to a year of either NAOD-001, 24 milligrams per kilogram every 4 weeks, or placebo, and then there was extension therapy permitted after that. The primary endpoint on this study was best change in NT-proBNP between baseline and 12 months. And then secondary responses included quality of life markers, a 6-minute walk test, neuropathy score, renal response, and some exploratory analysis of NT-proBNP analysis, including the slope of NT-proBNP measurements over time with treatment. So these results are in the public domain, although there hasn't been a formal publication of this yet, but the take-home is the top bar here, which shows that the primary response of NT-proBNP response was not met on this study, with actually less patients on the NAOD arm reaching response compared to placebo. And then, although there was a slight increase in the number of renal responses in the NAOD group compared to placebo, it wasn't statistically significant, and all of the other secondary endpoints were also not statistically significant different. As a result of this study was declared a negative study, mostly on the basis of the primary but also the secondary endpoints. This led to an early futility analysis on another study that was going on at exactly the same time, which was called the VITAL study. Now, this was an upfront study for patients who were not planning to have a transplant, but were getting bortezomib-based chemotherapy. So these were newly diagnosed patients with cardiac involvement, CyBOR-D, with or without NAOD-001. Again, the NAOD was given as an infusion every 4 weeks. The duration of initial therapy was based on investigator practice, and patients were discontinuation of first-line therapy and initiation of alternate second-line therapy that wasn't transplant-based was also according to standard clinical practice and the determination of the treating physician. The primary endpoint on this study was a time to a composite endpoint of all-cause mortality or cardiac hospitalizations. And secondary endpoints are listed here and are similar to the secondary endpoints in the Pronto study, including the best cardiac NT-proBNP response, which was the primary endpoint in the other study. So the futility analysis was done after 103 out of 156 planned required events had happened. And what we saw here was that there was a slight improvement in the hazard ratio favoring the NAOD arm with a hazard ratio of 0.84. However, this was not statistically significant, and with the remaining number of events left, probably would not reach statistical significance, and as such, the trial was halted. And the program, with a negative Pronto study and a discontinued VITAL study, was actually halted. So at this point, the development of NAOD-001 is not proceeding. So we could look at this and we could ask questions, what happened? One possibility is that our hypothesis about the pathophysiology is incorrect. I think we've seen ample amounts of data, the data I showed you, the data others have showed you, that that's not likely to be the case. I think we're very clear that there's direct cytotoxic effects of these aggregated soluble species. The statistical assumptions that these trials were based on may simply not have been perfect. It's possible that we overestimated the effectiveness of NAOD-001 based on the phase 1-2 data. I think even more likely we've underestimated the clinical course of the placebo-treated patients who are getting current standard frontline therapy. And we're going to see great data during this meeting about the addition of bortezomib to alkylator-based therapy and how that's affected outcomes. So that probably is actually the issue. And then the other issue, of course, is amyloidosis is a rare disease. It is not feasible to do an endlessly large study, and there's a lot of debate about what the best endpoints are for patients in randomized studies with AL amyloidosis, especially since it's such a heterogeneous patient population. So where does that leave us with antifibril-directed therapies in AL amyloidosis? There's still one compound in development, CAL-101, which previously was called 11-1F4. And the first time most of us heard about this was in the context of imaging work that was being done with a labeled version of this antibody. And CAL-101 is an antibody that was developed against an epitope found on the misfolded light chain after it was incorporated into fibrils, and the light chain that was used in the development was actually a kappa light chain, but it turns out that the antibody is actually reactive against both lambda and kappa derived deposits, as shown here on tissue biopsies. We see both. We see immunoreactivity against lambda and kappa light chain deposits, and in a mouse model where amyloid is injected into the mice, we see that there's reactivity against kappa or lambda derived amyloid deposits in mice as well. There's been a phase 1A and phase 1B trial done with this antibody thus far. This effort's been led by Dr. Lensch. The phase 1A is a single dose trial with dose escalation for that one dose. The phase 1B is 4 weekly doses, again with dose escalation. The primary endpoint of this, obviously, is to figure out the MTD in a multi-dosing schedule. And secondary endpoints, again, because this is a light chain directed therapy, relates to organ responses in addition to the PK and safety work. The combined results of these studies so far, we have 27 patients with previously treated AL amyloidosis who've been treated. In the highest dosing cohorts of the multi-dose Part B, there were six patients each in cohorts 6 and 7. The patients had been on a median 6 months from last therapy, with almost all of them achieving at least a VGPR with last therapy. Organ responses were assessed at 8 weeks in the single dose portion and at weeks 5, 8, and 12 in the multi-dose portion. What we saw were no dose-limiting toxicities and no treatment-related deaths on this study. In terms of evidence of amyloid immunogenicity or immune response against amyloid, we saw a rash in one patient, which on biopsy turned out to be localization of antibody to previously unsuspected or unrecognized dermal amyloid deposits. We also had 12 patients with cardiac amyloidosis, 8 of whom had an NT-proBNP response, and we had 10 patients with renal involvement, 5 of whom had a reduction in proteinuria. There's been additional work done beyond just blood and urine marker testing. There's actually been some interesting correlative work done looking at echocardiograms of these patients. There's actually a very interesting abstract later in the meeting that really goes through all of this data, an oral presentation with Dr. Bhutani, who is actually one of our former colleagues at the Karmanos Cancer Institute, so I'm very excited to see that. This is just data about one patient on the study. This is somebody, we see here that before and after treatment, a reduction in NT-proBNP, but also importantly, mechanically, an improvement in global longitudinal strain. That's represented by the darkest bar near the top of this graph. And these are all of the patients with cardiac involvement. And what you can see is that strain improved in almost all of these patients, and the mean global longitudinal strain improvement for all of them was 1.69 points. When you look at the patient subset, and this is the data that's going to be shown in the oral presentation, when you look at the patient subset who didn't have cardiac involvement, these lines were all completely flat. So this reduction seemed to be limited completely to the patients that had documented cardiac involvement. So what other work's being done with this particular antibody? As I mentioned, this is an antibody that targets specifically AL amyloidosis light chains incorporated into fibrils. Work being done right now at University of Tennessee taking advantage of a peptide, the P5+14 peptide, which binds across multiple different types of amyloid fibrils, has been linked to an 11-104 or Cal-101 epitope. This combined molecule is called the P66 peptope. And the idea or the strategy behind this is that by pre-treating with P66, you can coat different types of amyloid fibrils using the non-specific P5+14 peptide fragment, and by doing that, localize antibody to different fibrils, effectively opsonizing them, even though the fibrils themselves don't have an epitope for this specific antibody. And the interesting thing about this platform is that theoretically you could attach an epitope for any antibody on here. So this is an interesting way to potentially broaden the use of this or other antibodies against amyloidosis. And just to prove that this actually does work, we have tissue samples of a patient with a tissue sample with AA amyloid deposits, transthyretin amyloid deposits, and then an AL amyloid deposit without particularly good binding to Cal-101, and we see that we are able to cause binding of the antibody to the AA and transthyretin deposits and enhance binding to AL. What would it mean to enhance the binding in AL amyloidosis? We have here mouse work done by the same group, and we see here mice that were treated with Cal-101 with reduction, clearance of injected amyloid deposits over a 17-day period. And when we compare groups of mice that were treated with just the antibody versus P66 plus the antibody, we see enhanced clearance of the amyloid deposits in the group that got the P66 peptope as pretreatment. So this might be an adjunctive treatment for AL patients, and it may, as I showed you before, broaden the usage of this to other types of amyloid. Another way to potentially sort of pan-target amyloid is to look for other targets that are present across different species of amyloid. And so one of those is SAP, which I think we've all heard about over a long period of time. There's been really decades of work in this particular area. SAP, or serum amyloid P component, it's a pentameric member of the pentraxin family with sequence homology to CRP. It's associated with basically all types of amyloid fibrils and actually accounts for a significant portion of the dry weight of the fibrillar deposits. We think that it has a stabilizing role on the fibrils and may prevent proteolysis. Two different anti-SAP drugs have been developed. The first is a palindromic small molecule inhibitor, used to be called CPHPC, now it's called Meridosap. And the idea of using that is it binds to and clears out soluble SAP, making way for desamizumab, which is an anti-SAP antibody that can then find its way to the deposits because we've removed the soluble sink. This antibody, when it binds, doesn't just opsonize the amyloid deposits, but it also fixes complement. And in the phase 1 study and subsequent phase 2 study that's been published, we did see complement levels drop in the majority of patients after treatment with this. And we also saw a bit of a cytokine release or an acute phase reaction response in some patients, but we also did see in some patients a significant reduction in amyloid burden. This is a SAP scan, and I think even from the back row and the size of this picture, you can see the difference in the liver of this patient in terms of the intensity of uptake. So a significant reduction in amyloid load. After a phase 1 and subsequent phase 2 publication in 2015 and 2018, there was recently an ongoing study, a 30-patient, 3-cohort study, one with cardiac transthyretin amyloidosis and 2 different AL amyloidosis subgroups. The first one shown here, the top pink bar, is again a group very similar to the group that we were looking at groups we were looking at before on the Pronto study and also in the Cal 101 work. After 7 patients were enrolled on this study total, the trial was halted. And the official word about this is the trial was halted and program discontinued because of, quote, a change in the risk-benefit ratio. This is the information around this isn't in the public domain yet. However, GSK is able to talk to you about it. If you inquire with GSK, you can find out a little bit more about this. But I expect that we'll have a formal published bit of information about this in the first half of 2019. I'm going to just, in the last few minutes of this talk, I'm going to change topics to transthyretin amyloidosis, which is really the focus of the remainder of this symposium after this. Transthyretin amyloidosis can be due to a mutation or in some patients, wild-type non-mutated transthyretin. If we remember that transthyretin tends to circulate in tetramers, and that's the physiologically functional form of transthyretin, but monomers are what get incorporated preferentially into amyloid fibrils. And it turns out that the epitope for an antibody called PRX004, which is present in misfolded transthyretin monomers, is visible, hidden in the tetrameric form, but present in the monomeric form. And we see here that PRX004 doesn't bind to the tetramer and dimer, but it does absolutely bind to variously sized aggregated transthyretin species. We've shown, it's been shown that it does bind to transthyretin amyloid fibrils, whether they're mutated type or wild type, in tissue, in this case cardiac tissue, of patients with transthyretin amyloid. The mechanism of action of the antibody, once it's there, is probably twofold. It definitely increases phagocytosis of amyloid deposits, fibrillar amyloid deposits, in a dose-dependent manner, as shown here. But it also it seems to inhibit fibril formation prospectively, suggesting that the binding site for the antibody on the misfolded transthyretin molecule may be important in fibril formation. So we're hitting it on both ends with this antibody. We're breaking down established fibrils, but we're also preventing production of fibrils in a forward manner as well. So this is an interesting mechanism of action. Right now there is an ongoing phase 1 study that's projected to have a maximum of 36 patients. It's being done at 7 centers, 5 in the US and 2 in Europe. This study is looking at 3 intravenous infusions, looking at safety, looking for dose, and also some really interesting work being done on pharmacokinetics and pharmacodynamics. And to do this work, there has been an assay developed to look at misfolded transthyretin levels in the blood. So rather than measuring total transthyretin levels, we're measuring the portion or the subset that's misfolded. And what we see here is that in patients with hereditary ATTR, the amount of misfolded transthyretin is elevated compared to normal patients on the far right. We also see that asymptomatic carriers who carry an abnormal gene also have elevated levels of misfolded light chains. And in the third group here, hereditary ATTR patients who've had a liver transplant, we see that liver transplant effectively lowered the amount of misfolded transthyretin light chains down to the levels seen in the normal group. And so this is going to be a very interesting assay to use for this particular antibody platform, but again, we also showed that it might be useful to monitor response to other types of transthyretin lowering therapies, such as ones we're going to hear about later today, newly approved RNA interference therapies. So this is a potentially useful measurement tool for these patients. Now, how best to use it, that remains to be determined. And the other thing, so far, this assay hasn't been useful for wild type transthyretin amyloidosis, so we're still working on that particular thing. So to summarize, in the last few minutes, there's been a lot of effort and interest in targeting misfolded protein aggregates because of the known role that they have in disease pathology. NEOD-001 and anti-SAP therapies were the ones that were first and furthest out of the gate. Both programs did hit major roadblocks this year, and both programs at the present time have been halted. However, we still have 2 other antibodies that are in development, CAL-101 for AL amyloidosis, and potentially others, as I showed you, and PRX-004 for transthyretin amyloidosis. I believe it's highly likely, as we continue to sift through the data from these first 2 programs, and there's a lot of it, and there's a lot of interest and a lot of work being done to look at the data and really tease it apart. I think it will guide the development of the future trials with other antibodies. Also to keep on our radar screen strategies like the one I showed you to help make these antibodies work even better and hopefully in a wider array of types of amyloidosis. And with that, I thank you.